it's a struggle for anybody as they're, working through the system and trying to figure out, which doctor am I supposed to see, or why is my bill so much, or why can't this benefit just work for me? So I think to me, I kind of wish that there was a 1 to 2 year mandatory program that every consultant or broker had to go through, where they go and work in the weeds in the day to day struggle that the benefits team has.
Welcome to Broken Benefits. I'm your host, Lee Lewis, and this is a podcast where we learn from top employer experts on how to fix our broken benefits to save lives, save dollars, and save your talent. Hey everyone, welcome back. So excited about today's guest, Neil Larson. Neil is a former benefits executive for one of the largest industrial firms in the country, where he managed a health plan with 80,000 people on it, speaking many different languages at many different time zones with different levels of education and income, with a lot of entry-level wages. And then after taking control and working with his team there, they were able to eliminate almost 10% of an approaching $500 million annual budget without cost shifting, to be able to get better benefits and better results for that health plan. After which he became a consultant. And then after that, he went back for an MBA at MIT and then became a data analytics expert within health and benefits. So excited to have him today. Neil, welcome to the show.
Awesome. Thank you very much. I appreciate it.
Oh, so kind of first thing, what is the best thing about leading a health benefits plan?
Before I led the plan, I was an actuary at the consulting shops as well, and spent a lot of time just kind of digging into the numbers and figuring out trend and trying to figure out what was happening. And sometimes you forget as you're processing all the reports and trying to put together some IBNRs or whatever it may be, you kind of forget the real people, and that it's a struggle for anybody as they're, working through the system and trying to figure out, which doctor am I supposed to see, or why is my bill so much, or why can't this benefit just work for me? So I think to me, I kind of wish that there was a 1 to 2 year mandatory program that every consultant or broker had to go through, where they go and work in the weeds in the day to day struggle that the benefits team has. Because that's one aspect, dealing with those issues directly with the population, going out to all the plants and meeting everybody. And then the second is really just understanding the operations of how much the benefits team has to do just to keep things rolling. And, there's nothing quite like having an executive call you on January 2nd saying, "Hey, my vision benefit's not working. My wife was just at the store. And it's what's going on here?" It's just a different kind of feel when you're trying to figure out why SAP is not working and why the executive's mad at you, et cetera, et cetera. So just being in the trenches just changes your perspective.
Oh, isn't that? I love that idea, and I think that's why the best consultants have run benefits plans, and vice versa. A lot of great benefits leaders who have worked in consulting. It really does round out the perspective. What do you think about risk and risk tolerance? Improving the system means stepping outside of the norm. And I'm curious about some of the biggest risks that you took that paid off.
I like that question. I think it's critical, who's taking the risk and what risk are they taking, right? So I think a lot of times we forget everybody's a person, and everybody's got their motivations for their own personal life, and then for their job, and then for the plan members, et cetera, et cetera. And that we can get all down this rabbit hole about what it means to be a fiduciary and how that should change your approach to risk. But again, if I'm putting my benefit manager hat back on and saying, well, what's my biggest risk? I go and I report up to the executives a couple times a year. I'm having lots of conversations with them, but that price tag and that big, hey, guess what? We have an 8% increase this next year based on the trend we got from our actuaries. And it means this much money is being spent, right? In some companies, it's so large, it's hey, this year we're facing an 80, $100 million increase. How
Mm,
many phones do you need to manufacture, or how many shipping containers have to get through the port to pay for that next increase?
mm,
Um, but again, is that my daily motivation as a benefits leader, or is it on the risk side? If I make a big change and I move the needle, is my risk that the benefits aren't going to work, or that I'm going to have unbelievable employee noise? It's There's a lot of different forms of risk. It's not just financial. It can also be, reputational within your organization, outside of your organization. It can be within the population. Because again, you're working with people who have to use those benefits. And I think part of the challenge is making sure that if you want to take, bigger risks to try to really tackle the problem, you got to be upfront with that. You got to map it out and say, this is what could go wrong, but we've got to take some risks. Otherwise, here comes that $50 million increase. And if we don't do something about it, um, that means people's jobs. That means lower paychecks. You can always put it in terms that people understand and agree with, and motivate them to make a change. So
mm.
that's one level, right? It's like, hey, what are the risks that I'm facing? I don't want to lose my job, but I also don't want everyone to just keep paying more than they have to. Then the second is, well, how do you de-risk those elements? There's ways to tackle problems that say, well, this is what could go wrong. I was literally on just a call yesterday, and the conversation steered to say, hey, tell us what has gone wrong in the past. Let's give us every horror story you've had, vendor. We'd love to work with you, and we want to make this change, but we need to know what could go wrong. Let's talk about it. Let's see how we get ahead of it and help us avoid it. Because guess what? I'm understaffed, right? You just,
Mm.
as a benefits leader, shockingly, it's really hard to get the CFO to approve more budget, for your HR team.
Yeah.
It's just the way it is. You're almost always understaffed. You never hear of a benefits team saying, "Well, I've got too many people. I need new projects to work on." Right. But again,
Every
you can
time.
de-risk it with all the partners that you have if you just ask the right questions sometimes and really hold their feet to the fire. They make enough money that they should be stepping up and help you with these things.
I want to hear a story. So, what was something? Tell us a story about something that you were a little scared about, a little nervous about that you did as you were restructuring an enormous health plan, and and then tell us what that conversation was like with your executives.
Well, our executives in the industry we worked in, it's a very low margin, right? And so we know going in, and we've received the message loud and clear that it was time to be hyper aggressive. So we were in a little bit of a situation where we knew that they were willing to take risks, right? Now, again, they don't want noise. They still want the benefits to work. And as much as they're willing in an executive, boardroom to say, let's take some risks, let's cut some cost and be aggressive here, still has to work. I mean, they can say that all day long, and then if something comes back and is a disaster and creates a ton of employee noise, they're going to forget that part of the meeting, and they're just going to keep pushing on that. So,
Mm.
um, but it did help to get the conversation started that they were in a, again, if we're only making 2 or 3% EBITDA, then we've got to be aggressive about those increases. So that's one element. You got to know your audience. Um, but the second is really just the system is not designed to help you, right? It's not like if you just keep doing what everybody's been doing and keep pushing those buttons that you're going to eat away at trend and you're going to be ahead of the curve. So some element of risk taking is required. It's saying, okay, well, I have to make some change because this plan has been stale for years on end, and we've just been eating trend, and it's just going to keep continuing. I think that's one of the biggest things. It's like, are we doing the same thing that everybody's been doing? And if so, then we're going to get the same trend that they've been doing. So how do we do a little bit differently? And that to me is kind of the element of walking into this saying, okay, this medical plan, we need to change who we're partnering with. We need to get a new look at how networks are calculated and how we're going to position which is the right network for us. The old tools are stale, so let's find a new lens. Do we need to be with a TPA because they give us access to specific things? It's always, well, should I be with a carrier TPA? And you have these high level conversations, but there's a specific conversation that needs to happen for the situation we're in and the problem we're trying to solve. And in that time, we wanted to solve the problem of high cost claimants. And we felt like the situation we were in, we were getting very little traction with the reports that would come back and the annual review meeting we would have.
Hmm.
Were they saying anything that made us confident that, high cost claims were being actually managed and looked at, and utilization and care management were doing what we would hope they would do?
Hmm.
I mean, honestly, no. That's why we got aggressive. And additionally, in that particular situation, the number one thing we wanted to change was how high cost claims were audited. It's, are they just going through an auto adjudication system? And if that's the case, how confident are we that that's the best in class? You can hire a company for a number of different reasons, but usually there's one or two things that stands out. And most of the time, you make your decision based on who has the best network prices. Right? Okay, great. That makes sense. I want whoever's got the best prices for where my people live. That could be
Hmm.
United's network. It could be the Blues. It could be whatever it may be. Cigna, Aetna. Um, but again, they do a lot of other things for you. They do claims processing, they do utilization management. You bundle all these services together. And you hear
Hmm.
that phrase total cost of care for years. But what does
Mm-hmm.
that really mean? You got to dig into it and figure it out. As we're looking at these things, and again, I'm going to go a little sideways here, but since the Affordable Care Act was passed, high cost claimants are through the roof. And it's a total structure of incentives problem, which is, well, now that there's no cap, right, on how much a healthcare plan can pay out per claimant, guess what? I'm going to send bigger and bigger bills through every year. And that's,
Yeah.
hospital systems make a ton of their money. But that means I can't be asleep at the wheel anymore on how my high cost claims are processed. So that's something we particularly wanted to focus on and made an aggressive change on. If you can get prepay auditing installed on high cost claims, there's a huge value to be created there.
Hmm.
So that's what we were aggressive about. That's what we wanted to achieve.
So hold on one second. I just want to make sure I'm following correctly. So you were in the position of managing this plan. You have low margins. There's an enormous rate increase. Uh, you have to do something different and new if you're going to maintain sustainability and maintain affordability for this plan. You look at the cause of the skyrocketing prices, and it's very clearly exacerbates in high cost claims. And so you speak with your carriers about, hey, what are we going to do to stop this? Because it's trashing the financials of my health plan. And they don't have any good answers. So you find an answer of your own, which is you're gonna take a proactive stance on these high cost claims and start taking care of and analyzing them prepayment. The carrier tells you you can't, but a TPA can. However, that's leaving the known path. You're leaving the paved road onto maybe the dirt road a little bit. And so this is the decision point that you're coming to. And what happens next?
Well, I mean, getting the decision approved comes down to, I mean, the credibility and the confidence you have in two things. One, that you've built up with the leadership team, but it's one of the
Right.
reasons I was brought in is saying, hey, we need to do something different. Benefits is in a, I don't want to say shambles, that's not the right word,
Sure.
but is in a situation that needs some attention. We'll put it that way.
Yeah.
And so that's one of the cards, we wanted to play early on. And, my leader also had a ton of credibility. And so she helped get that message across to all the executives. So that's one of the keys, is to get that message across. And then the second is, do you have credibility in the solution? And I
Mm-hmm.
would say in that particular instance, we had a fabulous consulting partner, right? And in particular, I've always said you're not really hiring a consulting shop. You're hiring a specific set of consultants and a team, right? I mean,
Mm.
there are lots of fabulous people throughout the industry, but it's kind of sporadic. And so, who in particular as was helping you on that case? And we had somebody who was fantastic, who their job wasn't just to keep the commissions rolling. They really saw themselves as someone who, let me roll up my sleeves, dig in, and do the homework for you, and help you build solutions that work. And so she, did a lot of background work on making sure, yeah, this is a great opportunity for us. They're credible. We could put the right, incentives and structure in place so that they're not asleep at the wheel. We even pushed, this change, saying, okay, you can't hire a bunch of other companies as your customers this year. We need to make sure that you're growing a reasonable and responsible rate so that we get the attention we deserve. So that was a big help. And that's a
Yeah.
total side note, but it's such a big deal. Am I having a partner that's willing to roll up their sleeves and help me solve problems and come up with new solutions? Or are we just doing the same thing that we've always, been doing? I literally had someone tell me the other day, our consultant came to us and said, it's not my job to save you money or to look for every penny that we need to find. It just kind of blew my mind. It's, well, then whose job is it in this ecosystem to come to the employer and help them see how they can navigate everything? I mean, this other thing that frustrates the heck out of me is, again, I made that comment before about as a benefits leader, I have so many obligations just to keep the plan running. Every conversation about, what is, SAP or Workday, doing, and how am I talking to the IT team to get that next thing coded, and how are the files transferring to all the various vendors and talking to each other, and etc. I could go on. Every benefits leader who's going to watch this knows there's a ton just to keep it rolling. How am I, as a benefits person in the weeds in those trenches every day, supposed to come up with the latest thing that the lawyers at Elevance or UHC have cooked up, or the latest, CVS Caremark or Express Scripts shenanigan? There's 1,000 different ways for money to flow out of the system and against your advantage. And you need partners who are willing to step up and say things like, hey, let's try this. So all of that, to get back to the core of your question, the next piece is, once you get that credible, you have that credibility, you get that buy-in, implementation's a beast. It really is. With a big wholesale change like that, I mean, we had one plant that spoke 32 different languages. It's at some point, you've just got to really put the shoulder to the wheel and figure out, how do we get all the message across, and who are the community leaders in each of these locations that we can partner with to get the messaging where it needs to go. How are we going to triage noise, because we're going to do a great job, but there's still going to be noise. Implementation is an absolute beast, and takes a ton of work. And so you just got to get everybody that you can to the table, including your team, including local HR, including your consultants, and including the TPA in the situation that you hire. You got to be aggressive, I think, about asking and requiring help.
You do a lot, I think, generally in the community to educate employers about how to structure consulting agreements so that everybody has the right incentives. And I was wondering if you could take a minute to tell us, what do most benefits leaders and HR leaders not understand about consultants and the consulting industry generally? And how do we use that knowledge to get either a better team or a better incentive alignment?
All right. I mean, this is the point where, if we were playing baseball, you just put a tee up, you put the little ball there. I mean, this is my favorite question. Incentive structure is, I don't want to say it's everything, right? But it's a huge, huge deal.
Yeah.
And if we really just step back and say, well, what's my goal? And what are the people I'm hiring? What's their goal? And do those align? And 99% of the time, they don't align. And if we really just stop and think about, well, how do people make money, and who are they accountable to? What outcome and behavior is that going to drive? And I'll give you a specific example first, and then we'll get to the broker consultant world. But think about the health plan themselves.
Yeah.
I mean the carriers in this particular instance. Affordable Care Act comes out and says, hey, you can only make so much money, right? 15, 20% margin. Well, if I'm only making a percentage margin, then my money goes up when the overall premium goes up. I mean, that's just basic math. I don't want costs to go down. I don't want premiums to go down, because I'm capped in the percentage of that premium that I can have. So how do I, make more money? All right, let those costs go up, within reason. And I still have to be a little bit competitive. But then on top of that, I got to funnel money back to myself. And so I need to have a pharmacy program, because that doesn't count against my profit margin. If I'm paying my pharmacy practice, or I'm paying some capitation rates, well, that's cost. That doesn't go against my margin, but it stays in-house. It stays in the big company. And so my incentive structure is to keep everything coming back to me as much as possible. That's the only way I'm going to make a ton of money, right? And now we can keep going and talk about, well, how do I split my attention and my focus between commercial ASO, fully insured, and Medicare Advantage plans? But again, if somebody has all of those features and functions in their portfolio, it's really important to understand where they make their money. Because if self-insured, these ASO plans are not my profit center. And, red alert, they are not their major profit center, right? They're not making a
Right.
ton of money off the ASO fees.
This is carriers.
This is
The
carriers. We'll
carriers
get,
in
this
particular.
is as an example. But if that's not my major profit center, that's not where I'm spending all my innovation and my time. And even when I go negotiate contracts, maybe I could leverage the payments that are going through ASO to get better prices on fully insured or Medicare Advantage, because that's where I'm going to make my profit. So, I mean, it's basic math, right? If I got a 15% margin on $20,000 premium, well, that's great. I can make $3,000. If I have a $50 ASO fee, then my revenue on that, I mean, good gracious, right? That's $600. That's just the revenue. That pales in comparison. But I still have to process the same volume claims. I still have the same programs, etc. For the most part. So you can see the incentives matter a ton on where they put their focus. So let's talk about, all right, when I hire a partner to come help me, what's their incentive structure? And I have this chart that I love. I should have brought it. But it's, if you go and map EBITDA margin from 2010 to 2024, right? So these are publicly traded companies, 10K filings, and EBITDA is just earnings before interest and tax and all those wonderful things, depreciation, amortization. It's profit, right? And that margin was like 11-12% for the big shops, back in 2010. Last year it was over 30%. So it's not just that, hey, we'll make more money as everyone's spending more money. We're going to get a bigger piece of the pie as well. And I'm responsible for going back to Wall Street every quarter. So every 3 months, people are looking at my numbers, seeing how much money I'm making. And that's what I'm accountable to. That's what matters. So if we look at that profit margin and how it's increasing, well, look, profit's a function of two things: revenue minus costs.
Right.
Okay, well, I either make more money, make more revenue, or I lower my costs. And quite frankly, I think both of these give you some negative incentives. Let me give you a couple examples. One, let's say I'm a consulting shop and I have a lot of different features and functions I can bring to the table, right? I need to help come up with strategic ideas. I need to calculate all your actuarial work, right? I love that stuff. I'm an actuary by trade. I also want to help you with your RFPs and maybe write some pharmacy contracts, etc. We can keep going on and on down the list. Voluntary. Am I the best shop at all of those things? That's the question, right? The odds are that every consulting shop is not the best at everything. But because my incentive structure says I have to make more revenue, I have to keep everything in-house. So I very specifically, if I think that there's a third-party pharmacy consulting practice out there that I should be using, most of the time that's going to be frowned upon because we've got these pharmacist consultants in-house. They're going to do a great job. Let's use them. Well, what if they're not the best? I mean, it's possible that they're not the best and there's somebody out there getting better deals. How would you ever know if you never asked the question, et cetera? So again, my incentives are keep everything in-house, even if there are third-party experts out there that might do a slightly better job for your employer, maybe more than slightly. I had this aha moment on that front, and I'm not picking on Mercer for any reason. Just many years ago, and I've never worked at Mercer, but I saw that they had started some sort of disease management program for like $12 PEPM. And I sat back and I was asking myself, wait a second, why are they doing this? Do they have any particular expertise? Or again, I'm not talking about them specifically in their program for any reason other than that's what clicked it for me and say, well, maybe they can hire the experts and do a great job here. But the number one reason for them to do that is just to keep the revenue in-house, and instead of shopping it out. And maybe there are third-party programs out there that are better, or maybe there aren't, and they just needed to build it up, and that's why they did it. But at the end of the day, it's every single thing after that. As a shop, my motivation would be to keep it in-house, to keep my revenue up, right? So the second piece of that equation, I've got my revenue, is cost. Well, how do I keep my costs down? Well, what's my number one cost? It's labor. I've got to hire expensive, talented people to work on all these elements. And, we can go down the AI rabbit hole of what's possible in the future, later. But for now, it's, if I have a lot of top talented people working on a case to come up with new ideas, dig into the weeds, solve problems, that's expensive, right? So again, I'm not talking about any particular individual consultant, but just in general, the structure says, I don't want to spend a ton of time trying to bake up new things and solve problems because that's expensive. And my EBITDA margin is going to suffer if I have these overly aggressive problem solving consultants working in the weeds, especially on smaller cases. And so let me kind of wrap that ridiculously long monologue up into this thought process of, if you go really, really far out on the skewed distribution of employer sizes, the
Okay.
vast majority of large, I guess we call them jumbo employers,
Yeah.
um, they don't just say, hey, let me, partner with a broker and have them take care of all of these things for me. And, they'll make some commissions, but, whatever, right? That's not how they function. They say very specifically, I need this problem solved. I'm going to bid it out, get the best deal, find the best people. And this is the bounds of how much that effort is worth. This is how much we're going to pay for it. And so what you end up seeing is much more specific, targeted consulting at those outer edges. But again, as you continue to go farther down, you get smaller benefit teams, less ability to handle some of those things on your own. And it gets much harder to run a piecemeal sort of consulting structure that way. And that what ends up happening is there's sort of this break point where the average employer at a certain size is no longer capable of saying, well, who's my best option for actuarial science? Who's my best option for RFPing on the pharmacy front? Who's my best, et cetera, et cetera. And again, they just outsource to one shop. That one shop just makes a ton of commissions on the backside. And you no longer have the same levers and controls and ability to understand, what's the incentive structure for any particular function that they're performing. And it's all blobbed together and you lose a lot of your power. Again, it's not easy to solve. You tend to need help to solve it because you need someone who knows how that stuff has always worked.
So now let's look at just a few practical baby steps. So if some of the listeners are running a health plan, maybe they love their consultant, or but for those who don't or are thinking they might be able to do better elsewhere, what are a few practical steps they could take? Just little simple things to improve their situation.
Yeah, I mean, again, it goes back to, what's the problem? What is the problem you're trying to solve? I
Okay.
start everything with what's the job to be done. It's an awesome framework. If you ever have a little extra time, just Google that, Clayton Christensen. It's a
That's right.
brilliant way to just look at the world. And so, as you frame that question, I think you just have to go a layer deeper. As a benefits leader, what problem do I need solved? And if I'm getting no pressure from leadership and everything's fine and my trend is okay, there are just a universe of people who aren't going to feel a ton of that pressure. And I'm not telling everyone everywhere that they need to be hyper aggressive and blow things up. It may be that you're happy with the finances, the executives are continuing to sign off on things, and it's smooth. You don't have a ton of implementation challenges because you're not having to change a ton of things, et cetera, et cetera. So it's not a universal prescription. But to your question, if there are people who are a little bit frustrated, is it because the costs keep going up and you're not getting enough new, fresh ideas? Well, then you need to RFP that consulting. You need to cast a pretty wide net. And one of the keys, again, is who is coming to the table at a particular shop and who's helping you find the consultants who have the right attitude, the right mentality, or willing to do things a little bit differently. I think that is one of those key elements. You may hire a broker to help you RFP all these carrier elements, but who's helping you figure out where to look in the carrier shops? Or are you just getting the same old batch of people just based on where your headquarters are? And is that the best way to find the best talent? It doesn't seem likely, but you could luck out. So, I mean, if that's the question, is I need, better strategy, that's one way I'd approach it. Had an interesting conversation the other week where they specifically were asking the question, well, what should we do on our actuarial work specifically? It's like, well, given who you are and your size and your public reputation, that conversation kind of landed, said, you know what? That's not the kind of thing we want to be hyper aggressive about, of trying something new. let's go with the tried and true. We need a 20-year FSA experienced person that, we just know it works. Let's not rock the boat on that front, and let's be very targeted about making sure that we feel comfortable with that kind of a change. So you keep going down, but it really kind of comes to those questions: what problem do you need solved?
Mm. You've spoken a fair amount about how when you do things that are new, sometimes there is disruption. How do we manage an implementation so that disruption doesn't derail us for future years?
Yeah, no, I mean that's kind of the, you don't want the winds to be taken out of your sail in year one and
That's
then just
right.
completely be handcuffed in years in the future. So, um, I mean, obviously, the number one answer is to be methodical, right? Is to say, okay, let's pick something that we have a higher degree of confidence that we want to start with, that's more likely to go well. Maybe we dip our toes in the water. I don't try to change 8 things in year one when I'm understaffed, right? So you just got to
Mm,
pick that battle and phase it in over a number of years. Okay, great. But in some instances, it may be that the motivating factor is that we are spending too much money. We need to be aggressive. We need to make big changes. So target that pharmacy plan, or let's target the core medical plan and make a big change on something that everybody's using and it's going to have a ton of high attention. Um, that is the kind of thing that's really high risk, and everybody knows it, right? Because if you make
right.
that change and it doesn't go well, whew, that can be
Yeah.
rough. That kind of goes back to that same framework of what's the job to be done. Well, we know we need to solve all these things, but if I want to avoid the pain and the problems of a broken
Right.
implementation, I really need to source what could go wrong. And you need a lot of expert voices in the room who've been through that to lay all those things out ahead of time. I mean, that's really
Mm,
what it comes down to. If you're not asking the vendor for their definitive list of, hey, over the last 5 years, you've done a ton of implementations. Tell me
right.
every horror story that you have. You're missing a real opportunity. The second is again, the amount of money that's flowing through this system and that people are making off of the employer health plans. A lot more people, we shall say, should be bringing a lot more resources to the table to help you, being on more calls, taking more action for you, whether that's the consultant or the broker, whether that's the carrier,
Mm.
whoever it may be. I think asking for resources who are dedicated to working on certain elements
Oh,
is
okay.
totally within the realm of reasonability. Again, you're talking about health plans that are spending hundreds of millions of dollars sometimes, and you got consultants and carriers who are making 7 figures on your case.
Mm-hmm.
People just need to be a little bit more aggressive sometimes about asking for help. And then I think the other piece of the equation, let's say you get all of the files set up correctly, and you get all of those elements structured properly, and you get the open enrollment system tested positively. It is communications, and I don't want to sound too ridiculous when I say, well, everybody's a little bit different, but they are, right? And so it's not like there's a one stop answer for, well, how do I communicate this change to my population?
Right.
If you've got an oil field service company versus food industry or versus retail, they all are going to be a little bit different in how they get their information, how they consume it, and how you need to bring it to them. But I think before you even begin an implementation project or plan or try to make a big wholesale change, most benefit leaders have a pretty good understanding of like how their people consume benefit information, and I mean how well they do. I think most of us would say not well at all, right? They're throwing away things that we mail to their home. They're, any flyers at the workplace are going straight in the trash. And if we're doing webinars, their view numbers are way too low. So it's, you can kind of almost break those things into two different pieces, right? Which is
Mm.
solving the communication challenge with your people versus running a great implementation. But if you run a great implementation and you don't have a good communication strategy and plan with your workforce, um, you're still going to struggle a little bit. And solving that could be, hey, how do I work differently with local HR? They always have their pulse on things a little bit better. What
Mm.
resources and tools can I give to them? What community leaders, depending if I've got really centralized populations like we did in our experience, we had 2,000, 3,000 people working in one small town.
Mm,
So it's a very different sort of environment where, okay, well, there are community centers and leaders there that are really well known that can help. Um, that's where people will go with their first questions. And so working with them was part of our equation as well.
great communications and local HR and engagement.
But you got to be careful
Sounds
there,
like,
though. I want to make sure local HR has a tough job, and they've got a lot going on. So
yeah,
it's not just let me drop it on their lap, but they've got to be a key partner,
right.
and because that's where people go, that's who they know, that's where they're going to get their questions answered. Um,
Sure.
so they can be a great partner, but they're definitely not someone just to dump something on.
Makes perfect sense. Now, I want to get your advice. You're an expert in data analytics. You have been for a long time, professionally trained, and then you were a chief strategy officer at one of the biggest analytics firms there are. I want you to talk to our audience about how we can find data that's actionable in an ocean of noise where, and I'm not saying that it's a, TikTok and social media or something like that, but the actual reports that we get from carriers and consultants, 90% of them are garbage and inactionable and unhelpful, and some of them are just loosely veiled marketing efforts. And we need your help. How do we get to crisp, clear, focused KPIs?
Yeah, yeah. I'm glad you said the word KPI, right? Which is, again, oh, man, I'm going to sound like a total broken record here, but what's the problem I need to solve,
Okay,
right?
what's the problem I need to solve?
But um, if I just have some KPIs for my healthcare plan, it's going to be, oh, I want to hit this PM. Well, how do I get there, right? I mean, I've got to be a little bit more targeted about the problem I'm trying to solve. So is it
Okay.
that I have too much utilization, or is it that I'm paying too high prices for certain things? So all of these questions need to be answered, but they have to be broken down back to sort of what you said, which is, well, what can I actually take action on? There's this
Right.
awesome book, from Michael Porter, and he's the strategy guru. 40 years ago, he wrote this one about healthcare 20 years ago, and one of
Hmm.
the really fascinating principles he came up with is, why is healthcare so broken? And his answer would be, because we don't have sufficient competition at the appropriate level, which is at the condition. It's saying, okay, well, how are we managing this particular diabetic event in this person's diabetes, or how are we dealing with this musculoskeletal issue or injury, or so it's not, well, let me analyze all my inpatient in one big bucket, or let me analyze my ER utilization in the aggregate. That's not good enough information for you to take action on. Um,
Hmm.
Instead, you really have to say, what is the key element and driver in my ecosystem that potentially we want to pay attention to. I mean, this sounds really generic. Let me get more specific. Um, when I look at a healthcare plan's expenses, I don't say inpatient, outpatient, professional. I have a different algorithm that's designed to break it down into, well, is it high cost claimant related? Is it chronic condition related? Well, which chronic condition sets? All right, if it is
Okay.
acute, what are the key core buckets of conditions or events that are really driving all these things? And nobody's going to be surprised when you come back and say, look, your big drivers are cancer events. You've got skeletal surgeries at a volume, and you've got a ton of high cost claimants that are centered around cancer or gene therapy or maternity and preemies, etc. It's not that there's this giant mystery when you walk into a health plan that their drivers are going to be usually that different than everybody else's, right? There's a
Right.
lot of rhyming, I guess we'll say.
Yeah. Wide variation is for small sample sizes. Big employers all have the same problems.
You prioritize them and say what's driving two different factors, right? Which is, okay, what's driving my increase? You can look at it that way and say, well, maybe I want to tackle that. But then two, you got to benchmark it to say, well, maybe I'm not increasing that much, and I'm just starting at a horrible place. It may be that I have a ton of cost in something that's way outside the norm, that's baked in. So it's not just that you should be looking at trend, right? I may let me give you a specific one. Good gracious. We came into this group, this is years ago, but they had a massive trend spike 3 years ago. And then from there, after that, for the next couple of years, they had 2% trend. So they're like, hey, we're at 2% trend. Things are great. It's fine. Like we're really managing things super well. It's like, yeah, go back 3 years. You ate a ton of cost when you made this change, and you've just been paying
Mm.
for it every year. And we were able to find ways. Again, they were with their own carrier partner, and so we found a way to just bring that back down. So just because you have a
Wow.
flat trend doesn't mean that your costs are in a good place. So you
Mm.
got to benchmark and say, why am I paying so much for certain things? So having said that, you put that framework in place, you look at these key buckets, these key conditions, these categories, and then you ask the question, what's the utilization, right? So is it just that I have more of these events? Okay, well, if that's the case, then I need to do something different. Or is it the price point, right? And price point is driven by two different things. It could be that my people are getting more expensive services because they're a little bit sicker, or I'm just paying more for the same types of services that I've been getting in the past. And so if you have a situation where you're paying more for certain events than everybody else, right, or more than you used to, you've got to ask the key questions of, well, why is that? So I need benchmark data telling me, am I with the right network? Am I getting the right prices? And again, that used to be a really universal question to answer. We said, well, I did a discount analysis, and it says that for where my people live, the best prices that I get are with, let's say the Blues plan. Okay, great. But
Okay.
discount analysis never went down to the provider level. It never went down to the condition level. It's supposed to be blinded at that level. That's the way it's built and it was done.
Right.
But again, let me start asking questions. Which provider set is giving me a good deal versus not inside this network? And is
Mm.
steerage a possible answer for me? Or do I need to go with another system? Or again, we can go all down these rabbit holes into specific examples. But if I know I'm paying more than the benchmarks for my services, then I got to start figuring out why that is. It could be a big network issue. It could be a particular facility issue. It could be, well, overall, my discounts or my allowed amounts are great, except when I get to these high cost claimants, right? We talked about that earlier. Those outlier provisions, all bets are off. You don't, a lot of actuarial analysis is cut off at 100,000. It's not even meant to tackle that. They basically say, well, if it gets too expensive, we're not even going to look at that, right? Like that's outside the realm of how we calculate discounts, and so you got to pay attention to those specific types of elements. So there's one, or it could be more granular. Maybe we are overpaying specifically on musculoskeletal surgeries. Well, then I need a third party program, maybe a carve out that does a better job of getting those contracted rates. There are companies
Mm.
out there that do that, right? Lantern is a good example. Or if it's not the price point, it's the volume, it's the utilization. Maybe there's another solution to consider that's like, hey, this is the group that's really trying extra hard to avoid the surgery. And there's programs out there that really hyper focus on physical therapy. So let's tackle that program. But if you don't know that your musculoskeletal surgery cost is driven by utilization versus price point, and shocker, it's probably both, right? But
Right.
then you're not sure which one you're going to pick first, right? So I could keep going. We could talk about that. You talk about the pharmacy front. Again, incentives matter. So let me analyze where all my drugs are going. Let me analyze, is the formulary actually doing anything for me, or is it only doing something for the carrier or the PBM?
Yeah.
And I was looking at a report the other day. It was like almost every big name GLP-1 drug was on the spend list, right? And it was in the formulary. I'm like, well, why in the world are they all on there? Why aren't we leveraging this situation to get better prices, et cetera, et cetera? So
Mm.
all of that comes down to figure out what those elements are and then tackle them specifically. And this really gets to one of my hot button issues, which is then what do you do, 12, 24 months later? And has anybody
Okay.
ever come back to you and told you, hey, we put in this program and here's the independent, clean ROI for what we did? Um, that's just so darn critical. And it's math that gets done wrong all the time.
Mm.
It takes a little bit of energy and effort, but if you do it, you can really find out and say, hey, what did we change? And did we move the needle on X, Y, and Z? Which, all right, let me connect those two dots. I'm going to keep monologuing you because this is a big deal.
Okay.
Um, if you're installing a program, maybe it's a third party point solution, maybe it's something custom you did, maybe you want to do some steerage, maybe you made a big change at a carrier. Um, whatever you're trying to do to tackle a specific problem, when you do it, you should expect a specific outcome, right? So if I'm installing a disease management program specifically for diabetics, right, and I want them to be in such better shape, they're managing their diabetes so much better. When you start that process, you need to know, what is that supposed to look like over the next 1, 2, 3, 5 years. Now, that's key because there's only a handful of things that are those big ticket items in your plan. Is it hospitalizations? Is it ER? Is it outpatient surgery? Is it specialty drugs? And if I'm not expecting to move the needle on any of those items, then my expectation for ROI should be dramatically different. And I use diabetes as a great example because if you actually engage a diabetic, which is a whole nother question of, am I getting really good engagement? But if you actually engage them and they start taking better care of themselves, maybe they're more compliant with their insulin, or they actually take their metformin like they're supposed to, or they stop eating all those delicious sweets, whatever it may be, um, I still don't expect dramatic changes in their actual healthcare utilization pattern, you know, for years, 4 or 5 years. Then I'll start
Right.
seeing maybe fewer comorbidities and complex situations. Maybe I'll see fewer hospitalizations. So if I install that program, I need to know, man, I'm probably not really actually going to lower my costs in the short run. And it turns out I'm a high turnover company. Maybe that wasn't the best thing for me to tackle. But
Right.
instead, if I'm putting in high cost claimant auditing, this is what I expect to see next year. Or if I'm putting in a carve out program for medication therapy management, because I specifically noticed in my data that I got a ton of people using a ton of drugs all at the same time from tons of different doctors. You can run that math. Well, maybe that's the program I want to do. What do I expect to see next year? Well, I should see that metric come down on the number of people taking a ton of different drugs from a ton of different prescribers, et cetera, et cetera. So
Right.
long rambling answer, but it really comes down to being very specific and deliberate. And again, the key overriding principle here is, as a benefits leader, you've got a ton on your plate. Somebody should be helping you with that problem. And it's
Right.
not good enough to just collect your data and spit out a 60-page report and say, here are a bunch of metrics. It's just, that's not the future. It's not what should be being done on your behalf. What you should be expecting and demanding from the people that you work with is something much more targeted about, here are the things that you can do and that you could potentially affect. So don't bring me a report telling me where my money went. Tell me, okay, this is what's going on in your healthcare plan that we can affect, and let's do something about it. And then again, the math is there, right? You know, the systems are only going to get better and faster, stronger. So this is not unrealistic. This isn't me saying I need an FSA to manually work a problem for 3 months and come back to me, and that's going to be an $80,000 bill, right? Well, if it's an FSA, it's okay. It's going to be $160,000 bill. This is the kind of stuff that computers can really, really accelerate.
What do vendors and consultants not understand about benefits people and the management of benefits that they should?
I said some of those things, right, around the pressure points and the day to day, and again, going back to, benefits leaders are real people that have real pressures on their careers, on their work dynamics, on their teams. So I think just being cognizant of those things is really valuable. And then again, well, I don't know where you go to get a PhD in benefits. I haven't done that yet.
Yeah.
I got into health insurance by accident, right? I was getting a degree in economics and realized, well, shoot, that's not a very marketable degree. What in the
Yeah.
world? Nobody wants just a bachelor's in economics. But I knew I didn't want to write any more papers, so I was ready to get to work. And I just happened to run into somebody who said, well, my professor that I was a big fan of, and he said, well, my dad was an actuary. You should consider that. You like math, right? And so I just, I was like, all right, I'll do an actuary, take some of the exams, and then ultimately at that decision point, I had to decide between retirement and healthcare, and somebody just said, "Well, healthcare is more fun. It's more like the Wild Wild West. You know, there are less prescribed rules." I'm like, "All right, we'll go for that. We'll try that." So the point of all that to say is, well, how did somebody get into benefits, and how did they get into the health insurance world, and how did they get into the position they are? And that just kind of changes the dynamics of what you expect that they have their pulse on. And I think it's just, again, as a partner who's supposed to be helping them tackle a massive industry with a ton of competing interest and a ton of broken incentives. This is broken benefits, right? So all the incentives are broken. If you know the day-to-day that they're faced with, and the fact that most of us got into benefits a little bit by accident, that changes your perspective on what you're bringing to them and how you're approaching it. I really think it does.
Somebody wants to reach you, can they reach out on LinkedIn? You're working as a consultant. You're helping lots of employers out. And I'm sure anybody who listens to this can realize there's a ton that you'd have to offer.
Yeah, I mean, there's a different way to do things. There really is, and that doesn't mean it's easy. I mean, that's for sure. It's a really tough system to work in. But as Bill Clinton said, right, I feel your pain. So
yeah,
no, I mean, there's just a better way. Yeah.
I love it. I appreciate you coming on today, and thanks everyone for listening, and we'll catch you next time. Thanks for joining us on Broken Benefits. If you enjoyed today's episode, please subscribe to our YouTube channel or on your favorite podcasting platform. Also, please share today's show with a friend or colleague. It's free to do, and it helps us spread the message to as many people as possible. Until next time.